Hey, what's up, Doctor of Physical Therapy Facebook page. Hey, I had a few folks that tagged me just recently who were hoping to have some discussion on cervical manipulation risk in light of Katie May's tragic recent case and then the coroner report that came out suggesting that the chiropractic manipulation may have been what caused the damage that led to her passing. I don't know if I'm doing this right. I've never done Facebook Live. I'm more of a Periscope guy. So I teach quite a bit of cervical manipulation and am fairly well versed on these screening issues. I don't really want to plug my companies on here to prove that yet, because I don't think that's what this page is really for, is for me to be trying to sell my companies. But I do want to just sort of jump in and talk a little bit about what's going on with this case and sort of my thoughts on it. I'm going to let my dog out of my room real quick. All right, so just to answer a few of the questions that came at me, first, the overall level of risk with cervical manipulation is extremely low. So let's appreciate that right off the bat, right? So if you look back at your clinical practice guidelines, this being a physical therapist group, if you look at Child's work in '08, you're going to see about 1 in 6 million, right? So the reality is that the risk, if you look at the trials in the past 10 years, the estimates are quite wide, right? What you will see is they are all extremely low. I actually took some time and did an average of the major published reports over the past 10 years back, and it was 1 in just over 2 million. But to me, I'm really big on utilizing our clinical practice guidelines. That ultimately summarizes all the data to guide our profession for managing these different issues. And so to me, I'm going to lean towards that and utilize that figure of 1 in 6 million. Understand, you guys, the reality is, and Roger Carey has admitted this in his work, or has pointed us to this, that we're never going to know for sure. And whenever you see a lot of variance in a data set, the one thing you want to realize is we don't know for sure. What we know is it's extraordinarily low. What we don't know for sure is the exact number. And the reason for that is there's never been a large scale prospective trial that we can look at in the literature. And the reason for that is it would be a tough trial to do. I mean, if we utilize our CPG data and say that a major serious adverse event happens in every 1 in 6 million attempts, it's going to be really tough to recruit enough participants to be able to have a large-scale, high-quality prospective RCT. And the recruitment would be challenging because you'd have to be telling these people, hey, we're going to do spinal manipulation on you. Then we kind of want to see who has a stroke, and then we're going to run that data, which really wouldn't be a very appealing pitch. I don't mean to joke about something serious, but I think that is a legitimate barrier to how we're ever going to have that prospective trial. So I think we're going to have to lean on more retrospective data. But what we do see when everybody looks at that data is the overall risk of serious adverse event with cervical manipulation is quite low. There's 2 major trials you need to be familiar with if you really want to dive in. The first one is from Cassidy in '08. I hope everybody's read that one by now. But that was published in Spine Journal. And basically what they looked at was when individuals presented with headache and neck pain, and they either received chiropractic care or care from their family doctor, there was no increased risk of having a stroke if you chose one or the other of those routes. In other words, there was no increased risk of having a stroke if you were treated for your headache and neck pain by a chiropractor compared to being treated by your primary care doctor. A very similar study was done in 2015 by Kosloff. That's Kosloff. And that was down here in the States. That was published in Chiropractic and Manual Therapies. It was a larger trial. There were over 1,000 participants. And again, what we saw is if you had headache and neck pain and you presented to either a primary care doctor or to a chiropractor, there was no increased risk in having a stroke to one of those 2 avenues. So what we consistently have seen in the literature is that there does not seem to be an increased risk of stroke by receiving chiropractic care versus receiving medical care for primary complaints of headache and neck pain. So what do we think is going on then? And what we think is going on is that when people have damage to one of their vessels, either the vertebral artery or the carotid artery, the damage to the actual vessel causes referral pain, right? You need to appreciate these are well innervated tissues, these actual tubes, right? The blood vessel itself is well innervated. So when you have damage to either the vertebral artery or the carotid artery, it refers pain to the ipsilateral neck and head, right? And if you want to read more about that, you're going to want to look at Roger Carey's work in 2008 and 2009. They have a couple articles, both in JOSP and MMT. Really good stuff. Roger Carey and Alan Taylor. And what they showed us is that when the arteries are damaged, the actual wall of the artery is damaged, there is referral pain to the ipsilateral neck and head, right? Now, this is well before the blood supply is cut off to the brain. So these individuals are presenting with what we call non-ischemic vascular pain. The blood is still going through to the brain, but the damage to the actual artery itself, the tube, the physical structure, is causing referral pain to the neck and head. The issue, of course, is that during the healing of that damage, there can develop ischemia, where now you do have the blood flow cut off to the brain. That's when you're going to see your 5Ds and your 3Ns. I don't know if you guys are still calling it 5Ds and 3Ns, but when I went through school, a lot of the ischemic signs were called that. And we all have that on our medical history on the medical history form, and that's great. And we obviously need to be aware of when someone's undergoing ischemic issues to their brain. But the bigger concern, because the odds are if somebody presents to you and they have they're intermittently passing out, they're having a hard time swallowing and speaking, I'm pretty confident that you guys are going to pick that up and say that's probably not somebody that's appropriate for cervical spine thrust manipulation. The bigger concern, and probably where we need to shed some light, is helping our students and new grads and experienced clinicians for that matter that aren't well versed in this area understand what vascular pain looks like that is not yet ischemic, right? So when the artery is damaged, but the blood is still flowing through just fine. And that is going to generally be a presentation of ipsilateral neck pain and headache. And that should be alarming and concerning because we love treating ipsilateral neck pain and headache. Right? There are very few things that respond better in PT clinics than ipsilateral neck pain headache. I mean, cervicogenic headache with spinal manipulation is a home run, right? But we need to have a vascular suspicion. When that person presents with ipsilateral neck pain and headache, we need to have a vascular suspicion. And that's where being a prudent practitioner really begins, is when someone comes in, they've got no ischemic issues on board, but they're presenting with a new episode of neck pain or headache ipsilateral. That's where the prudent practitioner has a vascular suspicion that they need to prove false before they proceed with mechanical intervention. Okay, so how do you go about doing that? Well, guys, the biggest thing is going to be in your targeted history, right? So if you look at Lucy Thomas's recent literature in 2015, both a nice piece in JOSPT as well as a masterclass in manual therapy. That's Lucy Thomas. Have a look at that. She's looked at individuals, right? So the article in JOSPT looked at two different groups, 21 people in each group. One of the groups had cervical artery dissection, so either vertebral artery or carotid artery dissection presenting to the ER. The other group had ischemic stroke without dissection. She then looked at their presentations prior of developing symptoms, right, and took targeted histories and tried to figure out what was it about the individuals that had dissection that maybe we could pick up in the clinic in light of concern of doing manual therapy on somebody who has an injured blood vessel, right? And what she found was a couple of things, but the biggest one that really jumped out was that there was a 60-time increase, a 60-fold higher likelihood of the individuals that were presenting with dissection that they had underwent minor mechanical trauma prior of presenting with the ischemic signs and symptoms. That, guys, is huge because what that should mean in your clinic is that minor mechanical trauma oftentimes can cause arterial dissection, which might then cause someone to present with vascular non-ischemic pain, which might then require you to pull that out of the history to realize this is not someone who has joint and soft tissue dysfunction. This is somebody who has blood vessel dysfunction, and I need to get them over to the ER, over to the hospital, so they can get an angiogram, right? So they can get a blood vessel analysis of the cervical spine, be it CT, MRI, or utilizing ultrasound. So that's the big one. So go read that Lucy Thomas article from 2015, and what it shows is the value of the history. Because minor mechanical trauma is often what generates vertebral artery or carotid artery dissection, which can then cause someone to present to your clinic with vascular pain that can then require you to recognize and refer. So when those people have a practitioner who has that vascular suspicion, and before you go in and do cervical manipulation, you're going to have to prove to yourself that this is not vascular pain, this is indeed mechanical pain that should and will respond well to manual therapy. You're going to take a very targeted history, right? So you're going to ask them, hey, preceding the onset of these symptoms, did you do anything vigorous, or were you involved in any minor mechanical traumas? And if you look at Lucy's article, you're going to see a lot of them were really minor, right? Painting, right? Having your neck in extension for a prolonged period of time and stressing those carotid arteries, right? Increasing your load at the gym and increasing the amount of compression that you're doing when you're lifting, right? Horsing around and playing tackle football. They were all minor mechanical events, but that can oftentimes be enough in someone, particularly if they don't have a very healthy arterial system, to cause some damage in the arteries that could lead down the road in that next month to an ischemic issue. Your history is critical, right? And certainly when you look at Katie May's story, the history was very relevant, correct? She had a very recent mechanical trauma that very likely could have caused damage to a vascular structure in her neck. And if you guys take a really careful history of that individual, when that shows up, you're probably going to err on, when in doubt, don't, and maybe getting some additional medical workup. And so you want to think about patients that when they're presenting, taking that really careful history. There's also other things you can look at. And I can't get too deep into this. It's a very large topic that I strongly recommend you guys go to a course and really get well versed on this stuff so that you can increase your overall confidence on who to intervene on and who not to, so that you're not withholding interventions from folks who are going to benefit, but you're also being prudent in making sure you're not intervening when it's not the appropriate intervention, right? But other things to look at is doing an atherosclerotic risk profile and understanding how healthy somebody's tubes are, looking at their history and their family's history. One other thing that shook out of Lucy Thomas's article was whether or not they had concurrent migraine diagnoses. So I believe it was about 8% of them did. So maybe those migraines have an association. Maybe that atherosclerotic risk profile. And then of course your really targeted history, while at the same time understanding that building a strong mechanical case can help to refute a vascular case. So when you have somebody showing up that very clearly or the data in front of you strongly suggests that they have mechanical neck pain. For example, they have headaches and they really meet that International Headache Society criteria, right? It's one-sided, doesn't side shift, tends to come on with prolonged weight-bearing postures, has neck pain associated with it, gets better with movement, right? When someone comes in with a case that really smells and looks mechanical, and then you go into your physical exam, in upper cervical mobility assessment, clearly you find relevant stiffness, cervical flexion rotation test is positive, indicating cervicogenic headache. When all of this stuff is present, your building of your mechanical case is going to refute your vascular case. The exact opposite is true. When you're looking for findings in that cervical spine that would indicate mechanical pain and presentation, and they're not there, that should be backing you off. So when someone has a negative cervical flexion rotation test, when you do mobility assessment on somebody's cervical spine and you're really not finding a whole lot glaring and you're not reproducing or changing their symptoms, these are things that should back you away from doing it, right? So understand it's always a balance. Taking that targeted history, atherosclerotic risk profile, really digging into their family history, getting a great understanding if they have concurrent migraines. These are all things that you can do to confirm or refute your vascular suspicion, to know whether or not you should refer out or go ahead and treat. And to go ahead and treat, you need to build a mechanical case that justifies that. And that means relative joint findings, relative special tests, relative history that suggests mechanical pain, right? So understand it is that balance, and appreciate that screening does matter. You guys will remember Louis Puentedura's article in 2012 in JMMT, where he was able to show that in the 134 cases of adverse event that did take place, almost half of those, would have been preventable with proper red flag risk screening. Guys, that's a big deal. And if you think we can cut those in half, and we were already at 1 in 6 million, we're getting to a level of low risk that makes this a very approachable intervention if you know your stuff. Guys, cervical manipulation is incredibly effective in the clinic on the right patient, right? And I don't want to see us not give people what they need, right? As little as possible, as much as necessary. We've got to use every gun that we have in conservative musculoskeletal management to help these folks get over barriers, complex, and wind up in a spot that they don't want to be in. So under treatment has risk. Under treatment has risk. At the same time, you got to know your stuff. You've got to be prudent. You've got to be safe before you're anything else. When in doubt, don't. So please look into some of those resources. And I hope that helps clear up some of the confusion that's out there regarding cervical manipulation. Again, it's a huge topic, the risk issue. And please go hit up a course and really dive into it. I have no idea how to turn off Facebook Live, so I'm probably going to be poking at my phone for a little while. But thanks so much, you guys. My email is jeffmooredpt@gmail.com. You're more than welcome to email me for further questions. Again, I don't want to be plugging my own company or courses, but you can reach out to me all over the web. So I'm happy to help if I'm able to. Thanks so much, you guys. Have a great what is it, midweek? Have a great rest of the week and have a great weekend.